Okay, so I think this one will be better. Abdrazak. I think this one will be better. Please encourage other people to join. I tried sharing my slides, but you people could not hear, so it is better I do this. Okay, so Abdrazak, can you hear me here? Okay, it's better. Very good. Please, other people, if you're here, please join. I tried sharing my slide using the laptop, but you could. If you have joined, please write your name. Let's start. Okay, Muntala Bello is here. He can hear me. Okay, Isra is here also. Okay, so I think this app is better. So let's use it and discuss. I wanted to use another one, but it wasn't possible. Let me see. Uh, okay, Isa Yusuf is here. So today's discussion, I will have to be the one to discuss without you seeing the slide, because this app I'm using does not allow me to share the slide easily. Sir AB is here. You're welcome. Okay, please encourage people to join now so that I can start. As you are all aware that diabetic emergencies are extremely important. For our new doctors, you will be the ones handling emergencies in the emergency ward, and it's very important for you to know the practical ways to handle emergency. This is no longer theory, but this is mainly practical. Right, so it is extremely important that you know how to manage emergencies practically, not in terms of theory. You have done theories, and the time for theory has passed, right? So it is important that you know how to manage emergencies. Okay, so please, if you have joined this new session, please write your name. Let's begin. So I'm sorry, the other app that I wanted to share using the laptop failed. I don't know why. It was showing the slide, but my voice is the most important thing in this discussion, so that you can hear me loud and clear. I will try my best to see. I don't know if you can see the slide so that I can share it. Okay. Sir AB and the rest. I don't know if you can see the slide. Is it clear, or is a bit further? Can you see the slide? Those who have joined, can you see the slide? If it is far, then we'll just talk about it. It's blurry. Okay, so let me just lead the discussion. Okay, no problem. Let me just lead the discussion. By the end of the discussion, I will try my best to share by the end of the course, or I will look for a way that other app can be more audible than it is. Okay, it's no problem. Let me just lead the discussion. So as I earlier said, we'll talk about okay, I understand. So we'll talk about diabetic emergencies, and you are aware that diabetic emergencies are responsible for mortality and morbidity in diabetic patients. Is one of the leading cause of emergencies in the medical ward in internal medicine. And the emergencies that you see in diabetes patient include diabetic ketoacidosis, hyperosmolar hyperglycemic state, and hypoglycemia. And I know most of you are aware of all these emergencies, right? So today we are going to be taking care of diabetic ketoacidosis. So I think for Abdurazak Abdusalam, we saw a case of diabetic ketoacidosis some days ago during our call. So, but for the new doctors, have you seen cases of DKA before? Sir Abi, Isa Yusuf, Yusra, who again that is here? Have you seen cases of DKA before during your postings before you became doctors? Have you seen cases of DKA before? Write in the comment section. This is going to be an active, okay. Yusra said yes, okay. Who again? We only have 6 people here. Okay, Niseba is here. Niseba, you are a senior person now. Okay, who again? All right. So, one thing with diabetic ketoacidosis is if they ask you, what do you mean by diabetic ketoacidosis? It's an emergency characterized by the hyperglycemia, the ketonemia or ketonuria, that's ketone in the blood or ketone in the urine, and metabolic acidosis, right? So our focus today is not about talking about the theory. I'm not interested in theory. My focus is to see how we can save lives, right? And we know that in type 1 patients, one of the emergencies they present with is DKA, and the reason being they don't have insulin. And if patients don't have insulin, they are at risk of developing DKA. Or type 2 DM patients can develop it when they don't have any insulin. For the new doctors who pass through my unit, you remember there is a term called total beta cell exhaustion. So if the beta cell is totally exhausted as a spectrum of type 2 diabetes, there won't be any insulin, and the individual will be at risk of developing DKA. So, but our interest is that if a patient comes to the emergency, rush to the emergency with DKA, you need to be aware of the precipitant, because managing DKA, very important for the new doctors and even the old doctors, is that you don't take your time. You're taking history, you're taking your time to examine. You are supposed to both examine and take history concurrently. It's very important, because one of the mistakes that I've seen over the years in my practice is that individuals, you have DKA coming to the emergency and you're taking your time taking history, 20 minutes, 30 minutes. That patient will go. Dr. Mutala, you'll be aware, like the DKA that you people resuscitated, right? So you have to take the history examination concurrently together. So one of the things that we want you to take during the small brief history is you have to take history of non-compliance to insulin. You know, type 1 DM patients are on insulin. Is the patient compliant? So these are what we call insulin factors. Is the patient compliant on insulin? Does the patient use on the dose of the insulin? Does the patient has poor technique of insulin administration? So very important, the technique is important, because if the patient is not administering the insulin into the subcutaneous space, some patients administer it to the skin, and that's why you see patients complain of pain and lipoatrophy and cellulitis. Some patients also inject it into the muscle where the distribution and the absorption is impaired. So you need to be sure that your patient does not have that. So it could be a precipitant, poor technique, and also poor storage of insulin. You know that insulin should not be stored in the freezer, neither should it be stored outside. It should be stored where the temperature is not too cold or the temperature is not hot, right, to preserve the insulin. So if your patient has been administering insulin that is already destroyed, you know, insulin is protein and is destroyed under heat. So if your patient is administering insulin that is already gone, then of course he is at risk of developing hyperglycemia and DKA. So other risk factors are infections like UTI or respiratory tract infection. So you quickly ask, is he having painful urination? Is he coughing? Is he having fever? Also myocardial infarction, acute pancreatitis, or non-adherence to dietary advice. So for those who have done my unit like Dr. Nuseba, you remember that especially young people with type 1, it's very difficult for them to adhere to dietary advice. You correct the sugar today, the next time they will go out and drink Coke and come back to the ward. So you'll be doing hourly control virtually every day, right? So that issue of non-adherence to dietary advice is a very important one. Okay, are you following me so far? If you're following me, say loud and clear. Type loud and clear so that we'll continue. If you're following me, write loud and clear. Isra, Museba, Mutala, Abdulrazak, Isa Yusuf. If you can hear me, write loud and clear. Okay, so you can hear me. All right, so you're following. Very good, very good. All right, so if the patient comes and you do that, please do not waste your time taking a lot of history. It's unnecessary. You just give that chance for complication to set in. So after taking the history, right, you should be aware of the criteria of DKA, because while you're resuscitating, you know, you take samples. So we know that the blood glucose should be greater than 13.9, or some people will say greater than 14, greater or equal to 14 millimoles per liter. Though for residents among you, you should know that it has been revised to 11.1, though it's not all the association and that has accepted it. So for pH is less than 7.3, bicarbonate less than 15, ketonemia, that's ketone in blood, greater than 3 millimoles per liter. For the ketonemia is more specific than ketonuria, because the ketonuria, the strip we have, only measures acetoacetate, and in the urine you have more of beta butyric acid, beta hydroxybutyric acid, than even the acetoacetate. So urine doesn't really tell you the true picture. So ketonemia is better. So there's a strip or a keto stick, just like a glucometer, that can check for ketones. So we have applied in our hospital. We are hoping that you'll be bought because it's more specific. So ketonemia of greater than 3 millimoles per liter, and ketonuria of at least 2 pluses. If it is 1 plus, it's not DKA, because there are other things that can give you ketones. Very important for Nuseba and Mutala. Very important for residents. You should know that starvation can give you that. Sometimes alcoholism can give you that. Severe stress can give you trace ketones. So for the ketonemia, you need at least two pluses. So 1 plus you cannot write, that is DK. right? So, what are the principles of management? We know them. Exactly, Nuseba. Sometimes, yeah, it's all boils down to poverty and lack of knowledge. Sometimes they decide not to use the insulin because they don't have the money, and other times is because they have some people will come and give them false hope of cure for diabetes, and that's what the main reason why me as especially I came into the social media terrain is to ensure that my patients have the needed information to live a healthy life, unless they decided that they don't want to live a healthy life. I like in my YouTube, for those who are following me, I have more than 66 videos, right? And I'm still doing videos. So that anybody that doesn't have good control, he should have himself to blame rather than lack of information. So for the management, the principles of managing decay, we have dissociation, fluid therapy, insulin therapy, correction of electrolyte imbalance, and treatment of precipitant. So for resuscitation, the airway, of chin lift, jaw thrust, you check the airway, any ill-fitted denture, you remove it, any secretion, you suction. Do we have active suctioning machine in the A&E? I saw one the last time I did call, though we didn't have a reason to use it. Mutala, Yusra, Abdul Salam, Abdul Razak, do we have active one so that if there is none, we can make complaint? Because DKA patients can come unconscious, right? So you remove any infiltrated. So we do very good. So any ill-fitted denture, any secretion in suction, right? If the patient, so you put white ball cannula on both hands. Yes, for the new doctors, you get at least green cannula, right? You put it on both hands. You take samples for U and E. You take samples for your analysis. Where you have keto sticks, you take samples to check the ketone. You check full blood count, and you quickly check your sugar. It is criminal for you to see any patient in the emergency without checking blood sugar. And that's what made me very angry the last time I had call where a doctor saw a patient, he did not check blood sugar. I am anything that has to do with diabetes I'm passionate about. And the patient happened to have DKA. So it is extremely important that any patient you see, you check you check and make sure that the blood sugar is okay, right? So after putting your white blood cannula, taking samples, you check the blood sugar and also calculate the shock index, right? So for the fluid therapy, we use 0.9 saline, that's normal saline, 1 liter start, 1 liter 1 hour, and the rest. But for practical purpose, right, as you are resuscitating the patient, you must write everything that the patient needs. You understand? Because we, like in this hospital, we don't have DKA or HHS pack like some hospitals have, where everything the patient needs is in a plastic rubber, where there is the fluid there, the insulin, the everything is there, right? But in this case, in this hospital, we do not have that pack. So as you're resuscitating, you have checked the blood sugar and you're suspicious that yes, this is DKA or HHS, you write everything that the patient needs. Okay, so let's run it over before we start talking about the fluid therapy. What are the things that a patient with DKA will require that you quickly write for the relative to go and buy before you before they come, at least you start the resuscitation immediately. So let's list them. Okay, so let's list them. Everybody: Abdusalam, Nuseba, Bello, Yusra, Isa Yusuf, our new house officers. Write the things that you write for the patients to go and buy immediately. Let me see. So from what you write will be some of the things. Okay, soluble insulin. Thank you, Niseba. We want to the management to create that hyperglycemic emergency pack. So it's from what you write I will write. So okay, let's be active. So somebody write normal saline. IVF normal saline, how many liters? Okay, Montella Road, normal saline, urine bag. Okay, catheter, very good. Catheter, urine bag, especially you need to monitor input and output. Very, very good. So the normal saline, how many liters will you write for a start? Okay, Israel says 6 liters. Yes, at least you can write 6 liters for a start. Okay, you need cannula, you need giving set. Very good. Okay, what else will you write for the patient? The patient, let me also contribute. The patient needs cotton wool, spirit, plaster, isn't it? Because how are you going to put the cannula? Thank you, Nuseba. You need insulin syringe, right? Very good. Okay, so if you have these 6 liters, you have your soluble insulin, you have your giving set, you have, okay, very good, you have your e-glove, you have your plaster and everything, right? So because as if you do not have those things in the A&E, that should be the first thing you should write while you are trying to resuscitate the patient. Because in a situation where you finish taking your resuscitating and there is no fluid, there is no insulin, there is nothing, you see your work will just be delayed for 30 minutes to an hour, isn't it? So it's very important, So if you get your fluid, 1 liter start, 1 liter in 1 hour. So this 1 liter in 1 start and 1 hour, that's 2 liters in 1.5 hours. It is very important because that will ensure that the intravascular volume depletion, the shock that the patient may be in, is corrected. So because if a patient is in shock and you start insulin, there won't be absorption. And if there is no absorption, you're just wasting the insulin. And that insulin is not that it's going anywhere. Later on, it will cause hypoglycemia. So please give 2 liters, then you assess. If the patient is not in shock, you continue 1 liter in 2 hours, 1 liter in 4 hours, 1 liter 6 hourly. As we are all aware, in DKA, the deficit is 6 to 8 liters, and you need to replace that within 24 hours, right? So, but it is important to know, right? This is practical, that some of the patients that will come to you, they have already received fluid in other hospitals. And if that is the case, that they have received fluid in other hospitals, then it is important that you assess the hydration status of the patient. So if you assess the hydration status of the patient and is well hydrated, instead of you doing 1 liter start, 1 liter in 1 hour, you just go ahead and start 1 liter in 2 hours and forward. At least you're sure that the patient is not in shock. So you go ahead from 1 liter in 2 hours. But if you assess, even if the patient has received fluid from other hospital, but if he's still in shock, then you need to start afresh. So you see that calculating shock index is very important. So for those who are not in teaching hospital that are in part of this group and those who join, for the insulin therapies, know very well that giving IV10, IM10 is obsolete. The only time you consider giving IM is when you are finding it difficult to give the IV. But IV and IM 1010 is obsolete. Please don't do that, right? You just start with 0.1 international unit per kg per hour. So if the patient is fully conscious, you can weigh. If the patient is not conscious, then you can estimate. So you do, as you're giving hourly insulin, you're checking hourly RBG check. So that means that you cannot manage DKA in a hospital that you don't have a functional glucometer and strip. And it's extremely important, very, very important, that in your managing DKA, you should not be distracted. So if you're two in the unit, one person should just stay on the patient, only on that patient. Because it's possible that you give 6 international unit, and before you know it, this is practical for the new house officers. You observe, you give 6 international unit, before you remember about the patient, it's almost 2 hours later, or sometimes 3 hours later. So it is very, very important that you dedicate your time on the patient and on the patient alone. So, and you are expecting the drop of 3 to 5 international millimoles per liter. If it's less than 3, you add 2. Meaning if it is 6, you can add it to be 8. But if it's more than 5 millimoles per liter drop, you subtract 2. That means if it is 6, you make it 4. So when the blood glucose is less than 14, you change it to subcute, right? And as I always say, that when you are changing to subcute, there are 2 methods, right? You can either use the daily requirement for somebody with type 1 diabetes, which is 0.5 to 1 international unit per kg. So me, I prefer using the 0.5, the lower limit, right? International unit per kg in 3 divided doses. Because sometimes if you use the upper limit, the patient may go into hypoglycemia. Another method is calculating the total dose of the insulin you used to reach less than 14 and divide it by 3. Let's say you use 30 international units to go or to reach less than 14. So you divide it into 3, that means you use 10 TDS. Alternatively, if you can as well continue using the insulin. If you want to continue using the insulin, you can, that's the IV insulin, you can use half of the dose that you were using hourly, you continue it IV, and you continue your normal saline. 2 hourly. So the half of the dose, let's say you were giving 6 international unit, you start giving 3 international unit 2 hourly and be checking the blood sugar if you don't want to change it to subcute yet. So, but if the patient is unconscious, right, you either do GKI or you pass NG tube, because you cannot give subcute and the patient is not eating. And remember, you give the last dose of the IV together with the subcute. What's the reason? The IV will serve as a bridge before the subcute start acting. For the new house officers and for also the old ones, if you will realize that if you don't give the IV together with the subcute when you are commencing the subcute, because some of you just write subcute 10 TDS and you leave, you come back the next day, the patient's blood sugar is 20 something. You have to be the one to serve it, not the nurses. So serve the first dose of the IV and the subcute together, then you'll be rest assured that there is a bridge before the subcute starts acting. Okay? So any question, please, let's take some questions before we continue. We'll try and finish on time. So any question, if you have any question, you ask. If you do not have, you type understand or understood. So, but if you have any question, especially concerning the insulin, If you have any question, please, you can type, you can write it. Our old house officer Abdulrazak, senior house officers, if you have questions, please ask, type it. So questions, if you do not have question, please write understood Neko. Yeah. If you have questions, please write questions, please. We have gone a bit far. Abdulrazak, any question? Niseva, senior person. Of course, Niseva. Okay, Yusra, any question? I want, because as I said, now it will be practical. Abdulrazak, Isa Yusuf, Mutala, any question? Anybody? Okay, Abdulrazak said, sir, if you are correcting and the patient sugar is 9 millimoles per liter by the last time, you still give the last dose of the IV and substitute because the calculation may tilt the patient into hypo. Okay, so see, if you, very practical question, Abdulrazak. So sometimes if the patient blood sugar is less, let's say around 9, right? I tell you the truth, if you still have to give the IV and the substitute, starting substitute, you are very sure that the patient is going to eat 30 minutes later. If you do not give the last dose of the IV, I can assure you the blood glucose will shoot up. So you must give it concurrently, right? You must give it concurrently, but you must also be very sure that the patient is going to eat. Because if the patient is not going to eat and you give the IV and the substitute together, I'm telling you, you're going to have problem. But if you change it to substitute and give substitute and the patient eats, most of the time the blood sugar will shoot up. So unless if the blood glucose after correction is normal, and the normal we want, right, is at least blood glucose level of maybe 4 to 7, right? That at that time you can even change to mistard. But if it's not between that range of 4 to 7, it is always better that you give the IV and the substitute together, so that you will not have the risk of the blood sugar shooting up. But if it's between the normal range of 4 to 7, I agree, you can just give the substitute either as premix or just soluble substitute. Very, very good and practical question. Any other question, or we can go ahead? If you want us to go ahead, please type go ahead so that we can go ahead. If there are no questions, please type go ahead so that I know that okay, so I've seen go ahead. Yes, I understand. If it is normal, I understand, Abdrazak. If the blood sugar is normal, 47, and you don't need to give the IV and the substitute. But if it is above that, you should not be afraid. As long as you are very sure that your patient is going to eat 30 minutes after the last dose of the IV. Okay, so okay, Hope you understand, Abrazak. Okay, very good. So, let me continue. So, let's talk about, we have talked about insulin therapy, right? So, let's go ahead. For fluid therapy, I told you that when you see the patient, you're supposed to take sample for U&E. And one of the things that you observe is there may be hypernatremia, but unfortunately, we do not have 0.45 saline, which is the ideal treatment for hypernatremia. Personally, I have not seen hypotonic saline in all my practice. And this is very dangerous because hypernatremia prone to the patient to brain damage, cerebral edema, and the rest. So that's one of the challenges that we have. If a patient has hypernatremia, we still give them normal saline, which is not supposed to be. Okay, so for the potassium, let me tell you the truth. If you are unable to get U&E in the first hour of treating DKOHHS, you are already at a disadvantage. Why do I say so? Because you are giving the patient insulin that can potentially cause hyponatremia, hyperkalemia, and you are not getting the result of U&E. So it's a very big challenge. However, it is extremely important as a resident, as a house officer, as a medical officer, that you must get U&E within 24 hours if you're taking, if you're managing DK. If not, I'm telling you the truth, you'll be treating patient with DK or HHS, patient will look fine, the next day you'll be told that the patient has passed. So it is extremely important that you collaborate and explain to the patient the importance of doing that test, and they must do that test within 24 hours. So that if there is a need to quickly correct potassium, you do that. Okay? So as we always say, when the potassium is less than 3.3, you don't correct. You don't commence insulin, you correct by giving 10 to 20 millimoles of KCl per hour with ECG monitoring, because of course you are given a very large dose. You must do ECG monitoring. So where there is no ECG monitoring or ECG monitoring, you'll be checking the pulse and the BP, looking for arrhythmias. You cannot be rushing KCl and not monitoring that. So, but if it is between 3.3 to 3.5, you give 30, 3.5 to 4, you give 20, 4 to 5.5, you give 10 KCl per liter. The initial one that I said of less than 3.3 is per hour, but the subsequent one is per liter. And if it's more than 5.5, you do not correct. So please, whatsoever step you are going to take to encourage the patient to do U&E within 24 hours is extremely important. But ideally, you should be getting it in the first period of your emergency, if possible every hour or every 2 hours, then subsequently every 4 hours. That's ideal. But we admit that we are in a developing country, a resource poor country, that we may not be getting in that 1 hour or 2 hours, but you must get it every 24 hours. So for the metabolic acidosis, of course, you don't need to correct unless if it is severe. And you know that we don't do pH, but at least you do bicarbonate. So severe acidosis when the bicarbonate is less than 10. And you correct by giving sodium bicarbonate. So if your patient is hypertensive, you use 8.4% of sodium bicarbonate in 400. So you give 100 mils of the sodium bicarbonate in 400 mils of normal saline over 2 hours. So if your patient is hypertensive, you use 4.2%. But if it's not hypertensive, you use 8.4%. Extremely important for you senior ones. They will ask you this kind of question in your MCQ in exams. So then subsequently you talk about treatment of the precipitant. I taught to you that the precipitants of DKA include insulin factors by teaching the patient proper technique of insulin. Please, if you do not know the actual proper technique of insulin administration, please ask us in endocrine, we will show you, or come to the diabetes clinic to show you. Because it's very important that if the doctor does not know, then nobody will know, right? Then teach the patient the right way to store his insulin and the right dosage. And you counsel the patient on compliance. If the patient has any infection, you teach the patient on broad spectrum. You give the patient broad spectrum antibiotic while you are awaiting your culture result. And if there are any other precipitant, you also treat them. Very important. But if you are giving the patient subcutaneous insulin and the sugar is normal, you need to change the patient to mixed or premixed insulin, as we popularly call it in endocrine, because mixed is a type of premix. So let me give you an instance, very practical example for you, Abdrazak, right, and the new house officers that will come in. If you are using, let's say, 10 TDS, or let's say you are using 12 TDS, right? That means you're using 36 for the patient. What is 2/3 of 36? Abdrazak or any other of the new doctors, what is 2/3 of 36? I want us to practically convert it, because you are going to discharge this patient on insulin. So you need to know the practical way of conversion, right? Because it's possible that you very good, 24, very good man, good, exactly. So if you get 24, what you are supposed to do, then you give 2/3 in the morning, 1/3 in the evening. So how much will you give in the morning and how much will you give in the evening? So give me the values. If you are using 24 and you want to give 2/3 in the morning, 1/3 in the evening, what will it be in the morning? What will it be in the evening? No, we said Abdul Mumini. We said that Dr. Abdul Mumini. Let me put your title well. No, we said that the total is 24, and you want to give 2/3 in the morning, 1/3 in the evening. 2/3 of that 24. That's what I meant. Very, very important. Because if you give 24/12, that means you are giving excess. The total you were using was 36. If you are changing it to mustard, you use 2/3 of it. That is 24. And out of that 24, you used exactly, someone wrote it, 16/8, right? So that's what you are going to use. Very, very important, 16/8. So you are using 36. For you, the total dose of the mustard or premix is 24. Out of that total dose of 24, you use 2/3 in the morning, that's 16, and 1/3 in the evening. So, exactly. So, why do we use higher dose in the morning than in the evening? Does anybody have an answer for me? I'll give you 2 minutes. If there are no answers, I'll answer it myself. Why do we use higher dose in the morning? Okay, exactly, Abdul Razak. Yeah, it's very good. My house officer is shining. Exactly. We eat in the more in the morning and in the daytime, right? So you eat in the daytime, you eat in the morning, you eat in the afternoon, right? And these two times. And one thing, another important thing is that in the evening, generally people tend to eat less, and after eating, they tend to sleep. So if you give them very high dose, they would likely develop hypoglycemia during their sleep. As we are going to discuss during our next week course on diabetes and Ramadan, but however, if it is during Ramadan, you reverse the dosage, right? We'll discuss it in detail, because during Ramadan people tend to eat more in the evening than in the morning. People don't take much during suhoor, right? Okay. So then if you have converted the patient to mixed type, what are the indications for discharge? One, the blood glucose must be normal. So the blood glucose must be between 4 to 7, right? Two, there should not be ketonemia or ketonuria. So you must have checked the urine or the blood for ketones. There is nothing. There must not be acidosis. So you have done U and E, and the U and E is normal. And you must have treated the precipitant completely. For those who are in my unit, you remember that I don't joke with UTI, because sometimes you treat UTI with broad-spectrum antibiotic, you think that the UTI is gone, but it's not, isn't it? Because there is risk of diabetic patients are at risk of having resistant UTI, right? And if you have resistant UTI, you have to be treated with the antibiotic that can kill that bacteria, like we saw during our ward rounds on Monday. A patient, he was totally fine, but he had E. coli that was resistant to most of the drug except gentamicin. So please do not discharge any of my diabetic patients or any diabetic patient if he has UTI without having urine MCS culture result. You'll be deceiving yourself, because the patient will come back. I have a patient that came back. She had UTI. I advised her to use a stronger antibiotic based on the culture. She used general antibiotic and felt fine. But she came back with worse symptoms of the UTI. Now she had to spend a lot of money and buy the Sofine to get that relief. You understand? So it's very important you completely treat the precipitant. Okay? So today the target was to discuss DKA, and this is the end of that discussion on DKA. So please encourage other people to subscribe to the channel. That's the only way they can participate as you're participating. But please, let's take questions, especially for the new house officers that will come in. If you have any question, please ask, because Dr. Mugana, Dr. Niseba, we don't joke with our diabetic patients. Don't come in and play with our patients. Me and you, we enter one trouser, is what they used to say, whatever. Okay, so if you have any question, please ask. Any clarification, any experience that you have that gave you a lot of trouble, please document. And one of the things that you experience for the news house officers is that sometimes the blood sugar is very high, and you check it's unrecordably high, and you're giving insulin, it's not coming down. It's not that it's not coming down, it's coming down, but it's just that it's above the level that the glucometer will read. Let's say if the blood sugar is 50 something and you are giving insulin, it may be coming down to 40 something, but the glucometer will still be reading unrecordably high. So if you have that instance, send sample to the lab to have an actual reading. So if you have any practical question, please ask Abdurazak, Chief Nusaiba, Isa Yusuf, Abigail, Yusra, Sir AB. I don't know if you're still here. So if you have any Bello Catalan, let's ask, because tomorrow I will not be discussing anything on DKA again. We will be entering detailed discussion on NSA. Okay, Sir Abi said he need clarification on the correction of acidosis. As I said, acidosis you don't correct, because the acidosis is as a result of the ketones. So if you are giving insulin and correcting the ketones, that means you should have corrected the acidosis. So, but in a situation where you have severe acidosis, where the pH is less than 7, where the bicarbonate is less than 10, then you need to correct. So you use sodium bicarbonate, right? Because bicarbonate, of course, will buffer acid. And because there is sodium there, if somebody is hypertensive, you need to use 4.2% of the sodium bicarbonate in normal saline. But if the patient is not hypertensive, you are not afraid of sodium, you can use 8.4%. That's 100 mils in 400 mils of normal saline over 2 hours. But as long as it is not severe acidosis, don't worry about it. When you treat your ketosis, you will correct the acidosis. Hope you understand, Sir AB, if I have answered your question. Please bring in more questions. Bring in more questions. So, Ivy, did you get the explanation? So, please answer. But if anybody has any other question, please ask. And if you, okay, noted. For Nuseba and Abrazak, do you have any suggestion on how we manage DKA or HHS? Okay, because this course, I will take a lot of, you will benefit, but I will also benefit, because I will take a lot of advice from you based on how I have presented the ideal setting and how we can improve the management of patients with DKA or HHS. Okay, so but it is well understood. Okay, so if you have, if it is mild hypokalemia, right, as I said, if it is between let's say between 3.3 to 3.5, right, you still give maintenance of 30. And the reason why you give maintenance of 30 millimoles of KCl in 1 liter is because you are going to be giving insulin. If you are going to be giving insulin, you must give that maintenance, right? You must give that maintenance. You understand? Because if not, the patient will develop hypokalemia and go. So no matter what, you must follow that algorithm. If it is less than 3.3, no insulin, correct. 3.3 to 3.5, 30 millimoles in 1 liter. 3.5 to 4, 20. 4 to 4.5, 10. You must maintain. It is dangerous to be giving patients insulin without taking care of the potassium. I hope you understand, Abdulrazak. Okay, Nuseba. Okay, Nuseba said we really need a DKA pack. I am going to, Nuseba, you know, whether you like it or not, you'll be an endocrinologist. So we'll sit down together with you and other members of the unit to see how we can write the content of the DKA pack, right? So that if a patient comes and he has maybe, is 10,000, 15,000, 20,000, depending on the components, he will just go and pay in the pharmacy and carry the pack. and we'll start resuscitating. I'm seriously thinking of it, and I will seek your input when I'm writing the request. So okay, no. So for Abrazak, if you are resuscitating with IV insulin, if it is 3.3, you don't give slow K. But if you are finished resuscitating, right? If you're finished resuscitating the patient, is on subcute, and you notice it's 3.3, I don't mind you giving slow K. But if you are giving the patient IV at the point of resuscitating and you are giving slow K, it will not be enough. But if you have already stabilized the patient and later on, based on your daily or subsequent check of U and E, you see that it's 3.3 or lower, then you can give slow K. I don't have problem. But not during active resuscitation. If it is during active resuscitation, you can't do that because you are going to be giving the patient IV insulin. Hope you understand. Okay. Okay, so very good. So please, so this is the one on the course. I'll try my best to be here on time. Please, let's try and be here on time. I have understood that this app is better than the one that was able to show the slide. So I hope I was clear enough with without the slide. Please, if you enjoy this today's first session, please write thank you sir in the comment section. Let me uh, let me get that response from you. I'll try my best to be as practical as possible. I don't want it to be theory, right? When you come for residency, like Chief Murtala and Nusaiba, then we can talk about the cognitive palmital transference and other big English, right? But today is practical because this course is about practical management to ensure that my patients will not die in any of your hands, but you give them the possible best. Okay? All right. Okay, you're most welcome. Thank you for attending. I appreciate everybody that came. Thank you so much for coming around. Thank you so much, Nusaiba, Abdurazak, Abdul Mumini, Salihu Ibrahim, Chief Mutala Katagum, Dr. Abigail, Dr. Dr. Absalom, Dr. Abdullahi Turu, and whosoever that has been able to attend. Sorry, some of you, your name is not attached to your YouTube channel, so I cannot see your name. Thank you for coming, Isa Yusuf. Please, tomorrow let time so that we'll be able to finish on time. Please have a wonderful evening and also a wonderful night. We'll see you tomorrow by God's grace. Bye bye.